The major topic which we are going to talk about among the rare bleeding disorders is the disseminated intravascular coagulation. The rare bleeding disorders were generally concerned about the factors which we talked about in the previous slides, but the main topic of discussion today is DIC, or the disseminated intravascular coagulation. It is a very common disorder. It does not come under the umbrella of rare bleeding disorder, so I just want to make that demarcation. DIC is very common, especially in the medicine floors, and you're going to see a lot of patients if you're working in the ICU who develop DIC. So a basic understanding of DIC is very imperative. A lot of people or a lot of students consider this is a very difficult concept to understand because there are a lot of labs, a lot of labs going up, a lot of labs going down. A lot of multiple systems are affected. But if you understand the basic pathophysiology underlying the disseminated intravascular coagulation, then it is very easy to understand everything, including the labs in this profile. So to start off, let's just start off by defining what is a disseminated intravascular coagulation. If we look at the term and if we break it down into different parts, the word comprises of three parts. The first part is disseminated. So disseminated means widespread. So this shows that this disease is not localized to one body system on one body organ. It is a disseminated disease. It is a widespread disease involving the multiple organs of the body. And it has a component of intravascular coagulation. So there are widespread coagulation profile. There are widespread clots that are formed in the vessels, especially in the medium and the small size vessels. That is the hallmark of a disseminated intravascular coagulation, or DIC. Widespread fibrin deposition or the widespread clot deposition. Quickly, let's review the coagulation cascade. What happens when we bleed? For example, if we have this bleeding vessel, to start off, there is vasoconstriction, which reduces the blood flow to that vessel. Secondly, primary thrombosis is formed, which is the platelet coming and sealing that blood vessels. One platelet comes and that activates further other platelets, and that leads to a primary hemostatic plug at that vessel. That plugs that vessel and stops it from bleeding. But that is a very unstable clot, or the very unstable plug. It can be easily washed away when the blood flow increases. To reinforce that plug, there is secondary hemostasis, and in this secondary hemostasis, the coagulation cascade is involved. There are extrinsic pathways concerning the factor 7, intrinsic pathways which starts from the factors 12, factor 11, and both of them converge on a final common pathway, the factor 5, and that further leads to activation of thrombin from prothrombin, and that thrombin further converts fibrinogen into fibrin. That fibrin is basically undergoes covalent bonding to form a fibrin meshwork plug, and this fibrin meshwork reinforces that platelet primary plug which is formed, and that leads to the secondary hemostasis and the strong clot being formed and stops the blood from oozing out of the vessels. So this was a basic ideology or the basic coagulation cascade. What happens in DIC is, in a normal person, there is a balance of the clot formation and the clot breakdown. Simultaneously, along with the clot formation, there is fibrinolysis or the clot breakdown going. Once a clot is formed and it has served its purpose and that area is sealed and the blood vessel is repaired, then that clot undergoes fibrinolysis and further onwards. So both of these processes are in balance. But in DIC, there are certain things which are because of the underlying medical disorders which we are going to talk about. There is a loss of this balance, and the weight tips in favor of the coagulation. So there is widespread coagulation and there is less fibrinolysis. So the widespread clot formation leads to multiple areas of intravascular coagulation. These clot formation consume the various types of platelets and consume the fibrin and the coagulation factors. Because of the clot formation, there is decreased blood flow through various organs, especially through the small and the medium-sized arteries. That can lead to multiple episodes of ischemia concerning the various organs. And on top of that, there is increased fibrinolysis, but that fibrinolysis generally does not keep pace with the clot formation. So Overall, the body is in a state of hypercoagulation, but along with the clot increase, there is also slight increase in the fibrinolysis. But that fibrinolysis breaks down the clots which are being formed, and that leads to the bleeding episodes along with it. And secondly, because of the consumption of the coagulation factors and the platelets, the body goes into a deficient state and as of these various factors which are important for the coagulation. So there is also an increase in the bleeding episodes or the bleeding diastasis. So there is a paradox in disseminated intravascular coagulation. Simultaneously, there are multiple thrombi being formed, which leads to an ischemia, and along with that, there is also bleeding from certain parts that leads to anemia and the bleeding diathesis. So it has both the pictures. That's why whenever we have a patient presenting with DIC, they will be bleeding from the multiple orifices. They can be epistasis or bleeding from the mouth, oral cavity, gastrointestinal bleeding. They can also have deep bleeding into the brain. So that's why it is a very scary disorder, and it has to be treated very promptly and aggressively because it can be very life-threatening. It has a mortality of 30 to 80%. And a lot of patients which you are going to see in the ICU with DAC, they are very sick patients and very critical patients. And they have to be treated aggressively with various symptomatic managements and the coagulation factor replacement. Now let's talk about what can initiate a DIC in a patient. What are the basic important causes of DIC? The most important causes is the sepsis. The most common one is also the sepsis, especially the bacterial sepsis, which is secondary to a bacterial infection. The most common ones being the gram-negative bacteria, like the Pseudomonas and the gram-negative enterobacteriaceae like E. coli, etc. Along with that, there can be sepsis episode by the Staph aureus or the Streptococcus or the gram-positive bacteria, but the gram-negative are the more notorious for the sepsis. And sepsis, a patient with sepsis, you are very commonly going to see patients with sepsis in the medical floor, and the most feared complication which we fear in the patients which has developed a sepsis is DIC, and we have to prevent them with aggressive antibacterial treatment or the antimicrobial treatment. It can also happen with certain viruses or certain types of fungi, but mostly it is common with the bacterial sepsis. Certain types of immunological disorders can also initiate. Certain factors deficiencies can lead to DIC development. Along with it, trauma. Trauma is a very important factor. With trauma, there is tissue injury, there is release of myoglobin. That myoglobin can initiate DIC in patients, and trauma can also, especially in the brain, trauma to the brain, because blood in the cerebral cavity is a very strong irritant, and it can lead to irritation of the various multiple lipids bilayer walls, and that can release the tissue plasminogen activators and the various activating factors. We are going to talk about the pathophysiology in the coming slide, but what happens in DIC is because of these underlying processes, there is release of certain factors that can basically activate the coagulation cascade very rapidly and on their own, and that eventually leads to hypercoagulability overall in the patient. So trauma is one common one. Certain types of drugs can cause them. It is very rare to have DIC in response to certain drugs, but you should also have a good pharmacological history whenever you are reviewing the causes of DIC in a patient, especially if there are certain types of antineoplastic drugs can lead to DIC, certain types of rare disorders. We generally do not use the drugs which are commonly used, which were commonly or historically related to the DIC anymore. But good pharmacological history is also important, especially if the other causes are not apparent. Certain types of vascular disorders, like in the various types of patient with lupus, like in immunological disorders, various vascular malformations or the vascular manifestations, they can develop DIC in these patients. The important ones are the envenomation, like venous, like the snake bite, especially the snakes which are vasculotoxic, which cause vascular injury. There are few snakes that cause neurotoxicity, but a few snakes which are venomous, they can lead to a DIC, and that DIC is the major cause of death secondary to the snake bite. The snake venom in itself can activate the coagulation cascade, and that can lead to the death of the patient in a very short period of time. One important aspect are the obstetrical complications. These are very important to understand, and they very commonly can cause DIC, especially abruption of the placenta, abruptio placentae, or any other placental disorder that leads to bleeding in the last trimester. It can initiate DIC on its own. A dead fetus inside the womb can also lead to DIC. If there is an abortion or if there is a fetal demise and there is a process of removal of the fetus or DAC or done, then that can also lead to that evacuation, especially if there is certain retained placenta or retained dead fetal products inside the female, that can initiate the process of DIC in that pregnant female. So it is very important, especially if we are evacuating a fetus or at the time of delivery, to have complete evacuation of all the fetal products. And whenever we have certain obstetrical complications like the placental abruption or the various types of eclampsia, preeclampsia, if they are causing the DIC, then the treatment is to remove the fetus, because fetus is the thing which is initiating that whole cascade. So we have to remove the cause in those cases, and that eventually is the definite treatment is the removal of the baby, the delivery of the baby in whatever circumstances we have. Certain types of liver disorders, they can also lead to DIC, and DIC can also be a differential diagnosis of certain types of liver disorders like liver cirrhosis. So it is also important to differentiate that whether the person presenting with these signs and symptoms has DIC or whether it's a cirrhotic liver that is presenting as DIC. It is one of the differential diagnoses, and we are going to talk about it when we are going to talk about the differential diagnosis. Certain types of cancers, especially the pancreatic cancer or solid organs cancer like the colon cancer or bladder cancer, they can, prostate cancer as well, they can secrete certain types of tissue plasminogen activators or the activation products which can activate the coagulation cascade. So these solid organ cancers are very important, especially the pancreatic cancers. If you have to remember 3 or 4 major causes that are the common causes of DIC, then the number 1 is the sepsis, number 2 is the trauma from any cause. Cerebral trauma is the one which I would like to remember, because it can lead to bleeding in the brain, and that bleeding can further activate the coagulation cascade. Solid organ cancers, these are a very common, DIC is a very common complication of these, especially the pancreatic cancer and the colon cancer, and along with it, the obstetrical complications. So whenever we have the signs and symptoms of DIC in a pregnant female, it is very important to rule out the various types of placental complications undergoing, especially if she is in the 3rd trimester and near the term. Now let's talk about the pathophysiology of DIC. We touched on it briefly in the previous slide. In this flowchart, we are going to talk about it in more details. So what initiates this, the whole coagulation cascade? There is a certain type of tissue injury or an endothelial cell injury, a break in the vessel patency. A vessel is basically cut open and there is bleeding. So that can lead to increased expression of the various type of tissue factors. Along with that, this tissue factor expression and the exposed collagen molecules, the exposed extracellular matrix, all of them lead to factor 12 activation, and simultaneously there is platelet activation to form the primary platelet plug, the primary hemostasis. Both of these are activated simultaneously, but to start off the whole cascade, initially we have vasoconstriction, then there is platelet plug formation, and then there is that platelet plug is reinforced by the coagulation cascade. So the end product of all of the steps which you all know about, which we talked about previously, is the generation of thrombin. And from the prothrombin is cleaved to form the thrombin or the activated factor 2. What this thrombin does, it leads to breakdown of fibrinogen, the factor 1, into its activated form, the fibrin, and that fibrin basically reinforces that clot and forms an leads to intravascular coagulation. In DIC, this intravascular coagulation goes wrong. So when it goes wrong, it leads to consumption of all the clotting factors, the factors 5, 8, fibrinogen, and the platelets. One thing is the intravascular coagulation, which on areas of the body which are normal, which do not need coagulation. There is no problem with the blood interruption there. That leads to ischemia of those organs, and simultaneously, because of the consumption of these clotting factors and the fibrinogen and platelets, there is simultaneously bleeding episodes. So both of these things go side by side. The fibrin microthrombi, which occlude the blood vessels, can lead to microvascular occlusion, and that presents as an ischemic tissue injury in the form of microangiopathic hemolytic anemia. Microangiopathic means that it involves generally the smaller vessels, the small and the medium-sized vessels, not the larger vessels like the aorta or the coronaries. It is a microangiopathic hemolytic anemia. Hemolysis occurs because when RBCs try to pass these smaller blood vessels, which are already occluded by these clots, these RBCs undergo difficulty in passing through these vessels, and when they have passed through a clot, they can their shape can get deformed, and they can transform into something like schistocyte, which is an RBC which with the various types of outpouring of the membranes. It is not a normal RBC, and also they undergo hemolysis. Both these RBCs which are deformed can be taken up by the spleen and can undergo the extravascular hemolysis. So there is a picture of anemia also in these patients. These fibrin thrombi are also being broken down by the plasmin with the fibrinolysis cascade, and that can also further aggravate the bleeding episodes. And along with that, when these fibrin products are being broken down, there is a release of fibrinogen and the fibrin split products. These FSP or the FTP, fibrin degradation products, it's a term which is used interchangeably. It denotes that there was a clot and it is being broken down. D-dimers is also a term which is used to denote the breaking of the clots. D-dimers is basically used when the reinforced fibrin, which has covalent linkages between them, is broken down. That leads to D-dimers. But if the fibrinogen is broken down or the fibrin monomers are broken down, that forms the fibrinogen split products or the fibrin degradation products. So you can think of D-dimer as being a subset of FTP or the FSP. Both of them signify that there was a clot and now it is being broken down. So these are also very important and specific for DIC. The most important lab test which you are going to follow for a patient with DIC is the fibrin split product or the D-dimer test, because that gives us an idea of how the body is reacting to the treatment and how is the prognosis looking for these patients. With the breakdown of these products, there is inhibition of the platelet aggregation and fibril polymerization, and that also can basically lead to the whole cascade of coagulation and bleeding occurring simultaneously. So this was the whole pathophysiology. Started off with the tissue injury, endothelial cell injury, activation of the platelet and the coagulation cascade, and then because of this abnormal activation of the coagulation, there is a widespread thrombi formation, and because these thrombi consume the platelets, the body is in a deficient state and it needs really the clotting factors to plug off a bleeding artery, and it cannot plug it off because all of those are being consumed everywhere in the body, and that's why we have a bleeding from the normal orifices. For example, someone who is bleeding from the nose, from the oral cavity or the GI tract. We're going to talk about the clinical features and the labs in the coming slides.